What is Pemphigus vulgaris? It is a rare autoimmune skin disorder that causes blisters or bulli because there is separation of skin cells. Pemphigus vulgaris is a type 2 hypersensitivity reaction, which is when the immune system produces antibodies that bind to the body's own cells. More specifically, immune cells called B cells produce IgG antibodies that combine to specific desmosome proteins, desmoglin 1 and 3. It is unclear what triggers this to happen, but it's thought that it happens in genetically predisposed people and gets triggered by something like a herpes virus infection or a medication like captopril or certain antibiotics. Loss of desmosomes results in loss of cohesion between keratinocytes in the epidermis and a disruption of the barrier function served by intact skin. Pemphigus vulgaris has an equal incidence rate in both genders, predominant in women 50 to 70 years old. Mouth is the only site of involvement in 50% of cases, and is the initial site of presentation in 75% of cases. The clinical features of Pemphigus vulgaris is painful ulcers. Intraorally, bulli appear on any part of oral mucosa and become ulcers, most commonly on buccal mucosa, followed by palate and gingiva. Extraorally, blisters appear on skin of face, back, or chest. Pemphigus vulgaris has a positive Nikolsky's sign. In this picture, we can see ulcers in lower lip, ulcers in buccal mucosa, and ulcers in skin of back. The diagnosis of Pemphigus vulgaris is positive Nikolsky's sign, Zang cells, tombstone appearance, demonstration of anti-desmoglin 3 antibodies by direct immunofluorescence on a perilegional biopsy give a chicken wire appearance. Anti-desmoglin 3 antibodies can also be detected in blood. We can see the chicken wire appearance here and the tombstone appearance. The differential diagnosis of Pemphigus vulgaris is mucous membrane pemphigoid erythema multiforme pemphigus vegetans. The treatment of Pemphigus vulgaris is based on disease severity. Lower doses of prednisolone and topical steroid for oral Pemphigus vulgaris. High doses of prednisolone combined later with steroid-sparing immunosuppressant for oral and skin Pemphigus vulgaris. Rituximab is effective in resistant cases. A case report. A 36-year-old male reported to the Department of Oral Medicine with a history of painful ulcerations involving the palate and gingiva for the past 2 weeks. History revealed that the ulcerations started initially as blisters and were associated with pain that was aggravated on chewing food. The ulcerations caused considerable discomfort affecting his normal oral functions. Personal and family histories were uneventful. This is an intraoral view showing generalized desquamative gingivitis with ragged shallow erosions and irregular erosions in the palate. Upon examination, areas of erosion on the palate and the lower vestibule. The gingiva appeared erythematous and showed numerous erosions on the marginal gingiva. The gingival mucosa exhibited a positive Nikolsky sign. Extraoral examination revealed no skin lesions. The differential diagnosis for this case was mucous membrane pemphigoid and erosive lichen planus. Based on the history and clinical examination, a provisional diagnosis of Pemphigus vulgaris was made. An exfoliative cytological preparation from the labial gingiva showed desquamated cells along with a few acantholytic cells, Zang cells, the latter having a round shape with prominent nuclei. The smear also showed mixed inflammatory cells, predominantly composed of polymorphonuclear neutrophils. A gingival biopsy was obtained from a perilegional site under local anesthesia and submitted for routine histopathological examination and direct immunofluorescence testing. This photomicrograph showing epithelium exhibiting spongiosis, tombstone appearance, suprabasilar split, and dense inflammatory infiltrate. This figure showing acantholysis of the keratinocytes, Zank cells, red blood cells, and inflammatory cells. Direct immunofluorescence showed prominent intercellular deposition of antibodies directed against IgG and C3. As we can see in this figure, immunoglobulin G deposited in the intercellular regions of the keratinocytes of the epithelium. And in this figure, C3 deposited in the areas of autoantibodies in the epithelium. A definitive diagnosis of Pemphigus vulgaris was made based on clinical, histopathological, and direct immunofluorescence findings. Treatment. Initially, the patient was prescribed prednisolone tablets 20 mg, which were to be taken twice daily. Topical application of Kinacort was recommended to be used twice daily on the oral source. The patient was given calcium and vitamin D supplements. A gradual reduction of the areas of ulcerations on the palate and lower vestibule and complete absence of erosions in the marginal gingiva was seen. The oral hygiene of the patient was monitored and scaling and route planning was done once the condition improved. After 2 months, the dose was tapered to 10 mg twice daily. Over the past 6 months, prednisolone was gradually tapered down as there was complete regression of the lesions. In conclusion, Pemphigus vulgaris is a serious disease, and if left untreated, it could lead to patient's death. Often, the oral mucosa is the first involved site, even before the skin and the other mucosal sites are affected. So the dentist may have the opportunity to play an important role in diagnosing the disease. With early detection, Pemphigus vulgaris is more easily managed. Thank you.